After 50 years, the research evidence is suggesting the end of the hyperactivity model for neuromusculoskeletal pain. These data indicate that the body's reaction to injury and pain is not primarily increased muscular tension and stiffness. Rather, muscle inhibition is usually more significant. A major reason that the applied kinesiology manual muscle test should be added to the standard chiropractic and manual medical diagnostic methods used by your healthcare provider is that most parameters of dysfunction identified in low back and neck pain patients have not been shown to precede the pain, but rather only to accompany it. An important exception is muscle strength, which can predict future low back and neck pain in asymptomatic individuals.
The applied kinesiology manual muscle test has been shown to accurately measure the functional ability of the human being, a simple, reliable, inexpensive, and time-efficient test that has obvious face validity. There are now over 100 randomized, controlled clinical trials showing that muscle dysfunction, and specifically muscular inhibition or weakness, is present in patients with musculoskeletal pain.
This research confirms many other reviews of this subject.
Lund et al. In 1991 reviewed articles describing motor function in 5 chronic musculoskeletal pain conditions. They were temporomandibular joint disorders, muscle tension headache, fibromyalgia, chronic lower back pain, and post-exercise muscle soreness. Lund's review concluded that the data did not support the commonly held view that some form of tonic muscular hyperactivity maintains the pain of these conditions. Instead, in these conditions, the activity of muscles is usually reduced by the pain. An ICAK-sponsored study by Caruso and Leisman fortunately provides concrete evidence that the classifications of muscles as weak or strong, as determined by the examinations of an applied kinesiologist, are objective and reproducible with experience and training. These researchers looked at patterns of force, timing, and movement for over 700 muscle tests with sophisticated, specially designed equipment. They used simple mathematical applications to find potential patterns of force and displacement that would correspond to patterns of weak muscle tests obtained from volunteers. The result was the creation of a model that was not only able to clearly discriminate between strong and weak muscles, but was also accurate 98% of the time for fully trained practitioners in applied kinesiology.
In other words, this research has demonstrated that there are reproducible patterns of force used by the applied kinesiology doctor, resulting in varying degrees of displacement of the limb tested, corresponding to the extent of the clinician's experience and training in muscle testing. Dr. Manohar Punjabi, the world's most published human biomechanical researcher, proposes that the function of muscles should be placed at the center of a sequence of events that ultimately results in back pain.
Punjabi's article is very important for those in the manual medical professions who are evaluating the existence and consequences of the spinal and other pain dysfunctions. The key technical factor in this hypothesis would be the manual muscle test that makes the detection of the muscular imbalances and spinal dysfunction cited by Dr. Punjabi identifiable.
Because of this research, even the American Medical Association, in its Guides to the Evaluation of Permanent Impairment, has accepted the manual muscle test as a reliable and valid method for evaluating functional, non-pathological neuromusculoskeletal conditions.